behalf of Spectrum, it's my pleasure to welcome my esteemed panel here today. My name is Raj Narayanan. I'm the Chief of Interventional Oncology at the Miami Cancer Institute and an interventional radiologist at the Miami Cardiac and Vascular Institute. I'm joined here by Professor Rob Martin, Professor of Surgery from the University of Louisville, Professor Peter Hussain from the University of Miami, who's a medical oncologist and with a special focus in GI malignancies. I have Hester Sheffer, who's here from the Amsterdam University Medical Center. She's an MD, PhD, and who's done a lot of research in irreversible electroporation. And Dr. Martin Meyrink, who's also a professor of radiology and the chief of interventional radiology at Amsterdam Medical University Center. And Dr. Mike Chung, who's the vice chair of radiation oncology at the Miami Cancer Institute, part of Baptist Health of South Florida. We're all here today to discuss about pancreatic cancer. Pancreatic cancer is one of the most lethal malignancies with very poor prognosis, and even with several decades of management options in this particular cancer, the improvement in the survival of these patients has been marginal, to say the least. So it is imperative that we pool all the strengths of the different specialties that are involved in managing this particular cancer and to give the patients a better survival option, which is what we're going to discuss today. It's more of a understanding between how each specialty targets and treats these patients with pancreatic cancer and how we can all collaborate to give better outcomes to these patients. So welcome, everyone. I'm going to start here with Dr. Peter Hussain. Could you please talk to us a little bit about how pancreatic cancer patients are staged?
Sure. Thanks, Raj. So we think about staging in the clinic from a clinical standpoint, not from a pathologic standpoint. Really, if you look at staging guidelines, it's based on pathologic stage, but in the clinic we use sort of a large buckets, localized versus metastatic. And then within the localized group, we have anatomically resectable, borderline resectable, and locally advanced unresectable. So those more or less approximate to stage 2 to 3. Most times we rarely see stage 1 cancers. So the first goal really is to confirm the diagnosis, and that usually requires some type of biopsy, right? And if the disease is localized, we normally do endoscopic ultrasound-guided biopsy. And if you confirm a diagnosis of adenocarcinoma of the pancreas, then we generally do body imaging with CT or PET. And if the disease appears to be localized, then you need some good contrasted image with a CT with pancreas protocol or MRI with pancreas protocol to get very good definition of the anatomy. And that will tell you if it falls into the anatomically resectable category versus borderline versus locally advanced unresectable. And those categories, I mean, we have expert surgeons in the room, but those are based on the extent of vascular encasement or interface with the arterial structures and the venous structures. So in general, if you have short segment involvement of the vein, the superior mesenteric vein or the portal vein, that would be considered borderline resectable. If there's no involvement, that would be anatomically resectable. And then any arterial interface would jump you into the borderline resectable category. If it's up to 180-degree interface with the celiac artery or the hepatic artery or the superior mesenteric artery, and then greater than 180-degree interface with the arterial structure or long segment venous involvement would put you into a locally advanced unresectable category, which we generally refer to as stage 3. So in general, you need some good contrasted imaging to do that, and some institutions prefer contrasted CT, some institutions prefer MRI with contrast, but either of those I think are completely acceptable for staging. In some places and in some clinical trials, people do laparoscopy for staging as well. I think I would say, Rob, maybe you can comment on this. The majority of people would not do a laparoscopy, but if you have something suspicious on imaging, that is something that can be considered as well. We know that if something looks localized, if you put a scope in, for example, there was in the PREO-PANC study, they did laparoscopy on all those patients, and they found about 10% of them that appeared to be localized had peritoneal disease or some other intra-abdominal metastasis on laparoscopic staging. So some people are doing that, but in general, it's imaging-based staging.
So for a stage 3 patient, it's considered a locally advanced pancreatic cancer, and because of the encasement of the vessel and because of the inability or difficulty for a surgeon to obtain a clean margin or an R0 margin, we call them unresectable. Is that a fair statement? Or?
So Rob can comment on that.
Well, I mean, I think we would call that surgically I would say more oncologically unresectable. There are subgroups and subsets of stage 3, that being 3A, meaning isolated celiac axis alone or isolated SMA alone, that do meet technical surgical resectability. And that gets into a number of different types of surgical metrics in regards to what that means. If you think you can surgically resect that, what are the quality metrics for that? The vast majority, though, I would say within the United States would agree. If you have greater than 180-degree involvement of a major arterial structure, celiac axis or the SMA, there are two, people would call that locally advanced or unresectable. Yeah.
So as we know with this particular disease, a very small amount of patients, percentage of these patients would be deemed resectable at diagnosis, and then a huge percentage, about 40%, would be stage 3 locally advanced, and another 50% or close to that would be stage 4, where the tumor has gone outside the pancreas. So given this kind of difficult situation with this disease, how are these patients triaged in your institution? How do they get to you as the medical oncologist?
So most times if somebody has already a diagnosis of pancreas cancer, and we know, if it's localized, they would generally come in to see both the oncologist and the surgeon, because the algorithm now is that even in patients with localized disease, most patients would be candidates for chemotherapy up front. And the surgeons are usually involved in the decision making in terms of, the staging. I usually have my surgical oncologist place supports as well. So, it's a med-onc, surg-onc usually initial visit for patients with localized disease. And then we plan a treatment course in terms of whether we decide to do neoadjuvant treatment, how long, and the interval restaging. And usually we see the patients together during that period. Now, if a patient comes in with symptoms without a diagnosis, of course, sometimes we see them first, sometimes the surgeon sees them first, or the gastroenterologist, and then they get worked up. And then once the diagnosis is confirmed, they get referred to the appropriate person. If it looks like it's advanced, usually come to me. If it looks like it's localized, it's kind of a combination of myself and the surgeon. And we, at least in my institution, we don't bring in the other specialties at the initial consultation, but we usually get them involved eventually, like radiation and interventional radiology. They come in at a later point.
So one of the very important trends in how different cancer patients are managed in academic and big institutions is the discussion of patients in a multidisciplinary tumor board. So Rob, at the University of Louisville, do you manage to get, I know we have all limitations of time and resources, but do you, in your institution, do they manage to bring every patient to the tumor board, or as many as we can?
We do. I think we bat about 75%, just because we have outlying hospitals. We're in the main, what I call quaternary hospital, and then there's 3 other tertiary hospitals or feeder hospitals. We try and make sure that all of those are at least initially presented, mainly to actually validate preoperative staging quality CTs. Commonly, these patients are staged just with single phase 5-millimeter cuts, which is not optimal, or at least making sure that we have appropriately deemed whether they are technically resectable, whether they are 2B or stage borderline resectable or locally advanced. We probably do a better job with that with the 2Bs and greater, because people are slightly less enthusiastic about doing whatever their therapy is first. The 2As is where we probably missed about 10 or 15% of those, just because they come in, they get diagnosed, and then they just kind of get started before we hear about them.
Absolutely.
Yeah.
So Peter, so given how these patients and the stages at which they're diagnosed, many of them are going to start on chemotherapy. So what is the preferred standard of care as a first-line chemotherapy for these patients?
So we're talking about localized patients?
Localized patients.
So there are two standard chemotherapy options. You know, I feel sort of ashamed to say that, you know, we've been using the same chemotherapy drugs for more than 10 years now. You know, the FOLFIRINOX regimen was initially studied more than about 15 years ago, and, you know, became widely used around 2011, 2012. And that hasn't really been upgraded since, right? So, and the way that we choose which chemotherapy to give patients is still fairly rudimentary, meaning that if a patient is young and fit and they don't really have a lot of medical problems, we would choose to give them FOLFIRINOX. If they are frail or other medical problems and we don't think they can handle an intensive regimen, we would choose gemcitabine. The only biomarker that I think I employ, which we can get back relatively quickly, is if I suspect, based on the history of the patient, knows that they have a BRCA mutation or some familial disposition. If somebody comes in and they tell me that they have a parent who had pancreas cancer or a sister or, you know, a close relative, then you know that there may be something that is increasing in the family of what we refer to as homologous repair deficiency mutations, and that could be inherited like BRCA. And those patients tend to do better with platinum-based treatment, so FOLFIRINOX. So definitely you would want to choose that. Even in a patient who may not be fit, we can select a platinum-based regimen that they can tolerate. So that's really the only biomarker that we use to select between those two, but in general, it's a clinical decision which are those two. And I think a lot of people have the sense that FOLFIRINOX is a little bit better than gemcitabine. You know, if you pick the same patient population, the outcomes are fairly similar, and in fact, there have been prospective studies in the US, including the SWOG 1505 trial, that you know, those two regimens look like they are very similar in neoadjuvant therapy. So, you know, in general, it's hard to make a strong case for one versus the other, but I think most people in a fit patient would do FOLFIRINOX first. And then there's some data, probably the next question would be the sequence, right?
Yes.
You know, if you believe that you're having a suboptimal response to FOLFIRINOX, there's some data to suggest that switching to the alternative gemcitabine can, quote unquote, salvage some of those patients and bring them back on track to have a successful surgical procedure and a better outcome. But in general, I would say that I prefer FOLFIRINOX up front if I can get it into the patient, if I think it's safe. And, you know, we use gemcitabine liberally in older people. And, I think both regimens are fairly equally effective.
So how long do these induction treatments last, and how are they spaced out?
So the FOLFIRINOX regimen is given every 2 weeks, and in general, it's a continuous reassessment process, right? So, you know, I tell the patients usually that the package includes 6 months of chemotherapy plus surgery, but, you know, whether you do all 6 months up front or whether you do 3 months first and 3 months after, I think the jury is still out on that. Most people would try to get in some chemotherapy up front, and whether it be 3, 4, 6, you know, the differences in different institutions. There's a concept called total neoadjuvant chemotherapy where people give 6 months up front followed by surgery. In the cooperative group system in the US, they've decided on 4 months of neoadjuvant therapy followed by surgery, followed by some more chemotherapy afterwards. So in general, if a patient is tolerating the treatment and you're reassessing them every 2 months and you're getting tumor markers during the treatment and you see that they're responding based on decline in tumor markers or some improvement on imaging, which is a little bit difficult to assess, but if you think that they benefit from treatment, we try to keep going. And there may be institutional differences. Maybe different people stop at 3 or 4 months, but we generally try to get out as much as we can before surgery because we know those patients have a much more difficult time tolerating chemotherapy after surgery. And there have been some studies like PREOPANC that show that you get more treatment into the patients, you know, the more, if you can do more upfront, as opposed to leaving some of it for the end or giving all of it after surgery.
So what are the main side effects that a patient can expect from either one of these treatments?
Well, in localized disease, it's curative intent treatment, right? So, the treatment is not easy. You have to maintain some dose intensity. So, I tell patients you will get fatigued, you will get neuropathy, eventually the platelet count will drop. But we don't want to push them to the limit that they no longer become candidates for surgery or you wipe them out completely with chemo, right? So we try to maintain as much dose intensity as we can. But for Fernox, there's a high rate of GI toxicity, including nausea, vomiting, diarrhea, neurotoxicity with neuropathy. So those are things that we reassess on a continuous basis, right? And you can adjust, of course, to get patients through the regimen. But I think it's easier for people to put up with it because they have the idea that this is a defined length of time. If you have somebody with metastatic disease, it's kind of harder to convince them to keep pounding them with chemotherapy like FOLFIRINOX indefinitely, right?
Absolutely.
But in the neoadjuvant setting, you have a shorter period and you can see the finish line usually. And most times you can get patients through those cycles.
So, Rob, Peter touched on it a little bit, but as a surgeon, in your institution or in your practice, is your preference to go with neoadjuvant therapy, or if you feel like a patient is a clear candidate for surgery, is it to take them directly to surgery?
Right. So, important question, complex answer, and I will try not to take up too much time. So, I think we break those down into clearly resectable stage 2As and then stage 2Bs. Both are surgically resectable up front. All stage 2B patients, we definitely recommend getting at least 4 months of neoadjuvant systemic chemotherapy. And that's clearly based on high quality imaging where there's clear abutment of commonly the vein is what makes it borderline resectable, to which we know our margin positivity rates are going to be closer to 30% if we do upfront surgery. We also know that the lymph node positivity rate is going to be closer to 90%. So that's a higher risk biology. They clearly should get it. 2As, on the other hand, it really falls under whether we find those kind of equivocal 2As. And the equivocal 2As are the ones that we stage to which there are 3 or 4 lung lesions of 5 to 7 millimeters in size that are of indeterminate nature. So they don't meet metastatic disease based on RECIST, but they're clearly not normal. We are worried about those. CA19-9 level for a stage 2A that has a CA19-9 level that's greater than 200 to 300. Again, another what we're like, maybe we're understaging this patient. And then someone who has equivocal or subtle lesions within the liver or peritoneum, those are all patients that we do diagnostic laparoscopy on. Just emphasizing the pre-opanc, we are finding that about 15% of patients who we think are early stage actually have sub-radiologically occult peritoneal or surface liver metastasis. So those are ones that we do. Now the split of that though is, I live in a larger city, 1.6 million, but I take care of 3 rural states. And so the other big decision making about giving neoadjuvant chemotherapy is the familiarity and the volume of the medical oncologist giving it. Because I have sometimes probably 100 different medical oncologists. Some who dabble in it because they are the closest cancer center, other who, just like Peter, live it every day. And so that's something that I think physicians and patients really need to assess in regards to, just like volume of surgery is an important surrogate marker where you get your big operation, volume of giving this complex chemotherapy is a huge decision maker. And so if we are giving neoadjuvant therapy, we make sure that we've set kind of what we call sort of 3 foundational guidelines. One is they can't lose any more than 15% of their body weight from first dose of chemotherapy. Second is that from a fitness standpoint, we need them fit. We're talking about an operation that takes 3 to 4 hours. So if a patient can walk for 20, 25 minutes, which is usually about a mile, 2 miles an hour, we feel that they are surgically fit enough for having that. So they've got to maintain that underlying fitness. If the neuropathy is causing too much, that they can't walk as much and they're sitting more, then that's maybe where we'll stop. And then the third is definitely emotional and psychological. There is that long-standing. I mean, when I tell patients that they're going to go on a 9 to 10-month journey from the time we see them to the time we potentially tell them they're in remission, we need to be careful about that because our surgical insult is a little bit more of a bigger hit than maybe the slower every 2 weeks or 2 weeks on. And so with that neoadjuvant, I strongly recommend surgeons who are doing that, they must see these patients back also every 2 months. It needs to be a collaborative effort. The medical oncologist is taking care of response, is taking care of bone marrow toxicity. They're seeing things in a different aspect. We have a different view of, is this patient starting to maybe become unresectable from a frailty standpoint, and really pushing that kind of prehab. I'll stop there just so I don't, yeah.
Do you have like, how long is the waiting period from chemotherapy to surgery? Is that a fixed period, or you assess it?
It's totally based on their bone marrow. If patients has had 4 months of chemotherapy and their platelets are still 150 and their white counts are normal, it'll be 2 weeks. If their platelets are in the 70s and they've already had to maybe have a dose attenuation because of thrombocytopenia, then those may be more 4 weeks. Our quality metric is that we try and make sure that we do not have patients off systemic therapy for a total of 8 weeks. So if I can take them earlier, that means I've got 6 weeks of recovery. If I have to wait 4 weeks, that really puts the emphasis on me, all right, I got to get them back to our medical oncologist in 4 weeks, because I start to get uncomfortable when they're off therapy for at least 2 months.
Yeah.
Yeah.
And do you like rehabilitate them to get them fit for surgery?
We do. So that's why it's critical that surgeon sees them first and sometimes every 2 months. So doing outpatient rehab, trying to encourage these patients, because if they come in marginal, we know they're not going to get fitter during that 4 months of systemic or 6 months of systemic. So that's why we really try and emphasize to them, because a lot of times they think, well, I finished my chemo, now I'm ready for surgery, and they are in a wheelchair or they need a cane, and we can still operate on them because cardiovascularly they will be okay. The problem is that puts them at a massive risk of permanent loss of independence postoperatively. Permanent loss of independence is an academic term in the United States, which means nursing home. And if you mention to any patient that they have a 70% chance of going to a nursing home, no one will take it. Yeah. So we try and prevent all of that on the front end so that we can achieve the overall goals. Yeah.
So if a patient has gone through the journey and now is ready for surgery and they get to you, what are some of the surgical options or techniques that are available for a patient with pancreatic cancer who's...
Sure, and it's an exciting time. I mean, again, there is still some old standing history that having a pancreatectomy was this morbid operation that takes 8 to 10 hours and has 2 to 3 liters of blood loss and 4 weeks. That should not exist. You should not be going to an institution that has any of those types of side effects. The good things about pancreatectomy now is that there are 3 major options. Robotic is definitely one of them. Robotic and laparoscopy, in my opinion, is an equivalent of a minimally invasive surgery. It's small incision surgery to which you are removing the pancreas with oncologically sound principles. The main decision maker as to whether you're a candidate for robotic or laparoscopic is going to be the institution, whether they do robotic or not, or whether they do laparoscopic or not. I would say they're both equivalent as long as they're meeting their oncologic. The key aspects in the oncologic is definitely going to be margin. Right? How close is it to the vein will dictate whether you... There is a far greater incidence of having a minimally invasive pancreatectomy if you're dealing with a mid-body, left side of the body pancreas or tail tumor. Those have been proven to be oncologically sound to getting a minimally invasive resection. And in all reality, I would say a robotic or a laparoscopic distal pancreatectomy or left-sided pancreatectomy is far superior to an open, just because of morbidity standpoint. Length of stay is less. Pancreatic leak rate, depending on your transection techniques, can be the same, but the overall morbidity is less. So from a left side, I think you have a much greater incidence of a minimally invasive approach. For a right side or pancreatic head tumor, that's really where the data is really almost equivalent between a robotic Whipple and an open Whipple. And the main reason for that, just for the audience to understand, it's really not the incision that dictates the length of stay in those patients. It's the anastomoses and how well they heal or how poorly they heal. That is what dictates a patient's length of stay. And a pancreatic leak or bile leak are the 2 greatest things that we worry about, now whether you're doing it robotically or open. And when those head-to-head comparisons with enhanced recovery and opioid reductions and things like that, they're all still hovering at about 5 days. You may have a smaller incision, but you're not leaving the hospital quicker. Okay. And so those are all still options. I think depending on your institution, there needs to be a set definitive patient selection as to which you're eligible for. For me personally, it's really about margin is the biggest thing that I worry about. and then making sure that I'm able to get an adequate lymphadenectomy for that type of staging purposes.
So would it be fair to say if a patient is being considered for surgery that they should search out or seek out institutions which have a lot of experience and deal with pancreatic cancer, have a lot of experience?
Single-handedly. And just for more granularity of that, that would be a surgeon that's doing it greater than 20 a year would be a minimum standard. A single surgeon, and then the institution needs to be doing it minimum greater than 60 a year. So, because the key part about it for physicians are choosing surgeons, yes, they are choosing me, and much as I would love to say it's all about me, it's not. I do about 20% of the work. The other 80% is anesthesia, surgical techs, having interventional radiology available 24/7, having high-quality body imagers available, so that when you see complications, you can get in front of them quickly and keep minor complications minor. Where people get into trouble with lower volume hospitals, and this is not to bang on them, is those minor complications are then delayed and diagnosed and they become major, and then we can't salvage the patient, and then really poor outcomes occur.
So Peter touched a little bit about the category called borderline resectable. So when you have a patient who's borderline resectable, so they're not yet completely ready for you to operate on them, what are some of the strategies that your institution applies to get these people from being borderline to maybe resectable?
I think without a doubt, obviously working with our medical oncologist and choosing the appropriate regimen. And when I say appropriate regimen, just like Peter has said, it may be modified FOLFIRINOX first, but after 2 months, if we're not seeing some interval response, now that response can be equivocal, as he can go into, and you can help us to even more, is if we're not seeing a drop in the CA 19-9, we're not at least seeing some degree of response by RECIST 1.1. Borderline resectables, we are also being a little bit more bullish about using CT PETs. Not that SUV is perfect, but it's another surrogate marker of response. Doing that first, but at the same time, they're seeing our outpatient dietitian to making sure they understand what their weight is and what their functional weight is. And they're definitely getting an outpatient physical rehab assessment to where they're doing a number of 6-minute walk tests, stand up and go. There are 4 or 5 easy assessments that will allow us to predict their underlying frailty, and then baselining that every 2 months so that we're reassessing it, so that it's really a multidisciplinary decision about whether patients are tolerating and responding to neoadjuvant therapy.
So we talked both now about patients who are resectable and borderline resectable, but then we also have this huge category of patients who, where I would say local treatments play a role in managing these patients. And Mike, as a radiation oncologist, what are some of the radiation treatment options for a patient with pancreatic cancer? Can you give us an overview on that?
Sure. So, radiation therapy has evolved over many, many years. And I would say the categories that most patients would be, or the types of radiation that most patients would be offered, fall into either standard chemoradiation, which is once a day treatment typically for 28 to 28 fractions, versus something called SBRT or stereotactic body radiation therapy, which is typically delivered in 3 to 5 fractions. SBRT is a technique that is becoming more commonly used over, I'd say at least the last decade or so. But I think there's a misconception among patients and physicians that SBRT is somehow a much higher dose that you're delivering, or that it's more effective than standard chemoradiation. And in fact, it's a big misconception in that the term SBRT really just refers to the fact that you're delivering a shorter course of treatment using stereotactic guidance, but it really has no direct relevance, or that the term doesn't really imply high dose versus low dose. So if you look at the outcomes that have been published for example, locally advanced pancreas cancer patients with standard chemoradiotherapy over 5 to 6 weeks versus non-ablative or what's considered standard dose SBRT, those outcomes are very, very similar. And what they show is that local control is good in the randomized data of chemotherapy alone versus chemotherapy plus standard chemoradiotherapy shows that there is a local control benefit, although not an overall survival benefit. So there can be some improved local control there. It can improve quality of life. It can help with pain. But the two fundamentally really are not different in terms of an efficacy standpoint. The SBRT is just, it's really more convenient. What's now emerging is that technology advances have improved image guidance, especially with the emergence of something called MRI-guided radiation therapy. And MRI-guided linacs permit significant dose escalation to tumors. So now that you are able to deliver ablative SBRT or ablative radiation therapy, which is in excess of maybe twice the prescription dose of standard SBRT. And these are doses that are routinely used for curative intent for example, early stage lung cancers and other cancers where it's really not, you're not facing the anatomic challenges of the bowel or the stomach being nearby the tumor. If you have a peripheral lung metastasis in early stage lung cancer, I mean, you can deliver a lot of radiation to a pretty good radius outside of the tumor and be okay in terms of toxicity. Those types of doses have been really prohibitive. It's been prohibitive to give those types of high doses with inadequate image guidance historically without, you know, having a high risk of grade 3 to 5 complications, and those complications have been reported with sort of standard CT guided or other non-MR guided approaches. But long story short is there's an emergence of this MR guided approach that also allows for adaptive radiotherapy, meaning that the treatment each day with the new MRI of the day allows us to, within a short few minutes, assess what the anatomy is of that day, if the stomach is fuller or less full, if the intestine is closer or less close, to identify those changes, to modify the dose distribution so that we're ensuring ablative doses are delivered to tumor and ensuring that ablative doses are not delivered to the surrounding organs. And so those, the data from those type of ablative MR-guided radiotherapy has emerged over the last, say, 3 to 5 years in particular, and they're very, very encouraging in terms of what we're seeing in terms of more durable and higher rates of local control. And there's a hint there that perhaps there's increasing benefits in terms of long-term survival for selected patients who don't progress typically after induction chemotherapy.
So we have two options. More common is SBRT, and then some centers or more centers are now adding MR-Linac as their option. So as a patient, what should they expect if they are going to get SBRT? How many days is this treatment going to be, and what kind of recovery are they looking to?
Sure. So SBRT, I'd say most commonly at most centers, whether it's ablative or not, is typically 5 fractions or 5 days. There's a variability in terms of whether those are 5 consecutive weekdays versus every other day. There's really no data to show that one is better than another in terms of efficacy or safety. In terms of toxicity, most patients who will get SBRT will tolerate it well. If you look at rates of grade 3 or higher toxicities, either with non-ablative SBRT given with CT guidance or ablative SBRT given with MR guidance, the grade 3 toxicity rates are somewhere in the 10% or 7% range, both acute and late. So most people tolerate it very well. You know, the most common side effects would be maybe some fatigue, maybe some temporary nausea, maybe some temporary decreased appetite. Pain as a result of this is very rare. Pancreatitis, I get asked a lot, is that, you know, I've actually never seen pancreatitis from SBRT to the pancreas before. Skin reaction doesn't happen. The dose is so conformal and it's a deep-seated tumor, so the skin dose is very low. So, you know, most patients really have minimal side effects. You know, the more severe complications that we are concerned about are, of course, related to the bowel and to the stomach nearby. So the risk of GI bleeding, ulceration, those risks exist and those complications happen. And that's really the main concern that we have when we treat these patients.
And with an MR-Linac treatment protocol, how many days are they looking?
So, you know, the ablative MR-Linac protocols, you know, most commonly are in 5 fractions. Increasingly, there are, at our institution, we're increasingly treating patients more with single fraction ablative MR-guided radiotherapy. And there are some, actually the very first SBRT literature for pancreas cancer came out of Stanford with single fraction cyberknife therapy. And that fell out of favor because of increasing toxicity. We're sort of trying to resurrect that now with advanced image guidance and adaptive replanning. And we've had some good outcomes so far, and there's some ongoing clinical trials looking at that more. But it's in that typically 5, but maybe shorter range.
If the tumor gets really near the duodenum, is that a contraindication for radiation?
So a lot of most of the tumors that we treat and that I treat are in the head and uncinate process, and they at least abut the duodenum. You know, what I would be concerned by and who I probably wouldn't treat with ablative radiotherapy are patients who have true duodenal invasion,
Yeah.
as seen on endoscopic ultrasound. But it is very common, and we commonly treat patients with at least abutment of the duodenum. There are optimization structures in the planning of the radiotherapy where we ensure that obviously we can't deliver ablative dose to the duodenum, but there are some dose gradients where we ensure that the ablative dose isn't given to the duodenum while we're delivering at least the most of the tumor in ablative dose. So, but yeah, we still treat those patients even if there's abutment.
So switching gears to the other local regional treatment option, which has been gaining traction over the recent years, is ablative treatment option in the pancreas. And in the past, we've had agents such as microwave ablation, cryoablation, radiofrequency ablation, which all use either heat or cold to treat the cancer, and mostly been tried in the open setting or in the surgical setting. And over the last decade, one of the new treatments that has been brought into this space is use of irreversible electroporation, or IRE. And Rob, you're the pioneer in using this technology in pancreatic cancer. You're both a surgeon and somebody who uses ablative treatment in the OR. So what do you think about the impact that this has made since you first started using IRE? If you can start with a brief description of this technology and how it treats pancreatic cancer.
Yeah, so this specific discussion is definitely around patients with locally advanced pancreatic malignancies. My interest in this really began when I started practice from 2002 to 2008. One of the surgical therapies for locally advanced pancreatic cancer was the ability to resect the SMA and reconstruct it. Some vascular surgeons, it's just basic plumbing. I'll take out that tube and I'll put a new tube in and the bowel will still get blood flow. So we did that for approximately 50 patients. The thing that we've learned, which again is the reason why we've gotten so far away from that, is that you're also resecting all of the neural structures. And so the malabsorption that occurs for patients who have isolated SMA resections for locally advanced disease basically rendered almost 80% of them intolerant to be able to tolerate normal amount of nutrition. All of them were on TPN. They may have been alive, and a year we assessed them. They agreed and they were happy they were alive, but if they had known they would have had this, they wouldn't have done it. And so that was a wake-up call. As a young surgeon who really wanted to make a difference in locally advanced, I was like, clearly the surgical resection mode is not a way to go. And so when irreversible electroporation came on the market, specifically looking at prostate cancer because of its ability to spare the urethra and the prostate structures, I was like, well, wait a minute, this is going to be a much greater unmet need around in pancreatic, because clearly I need to spare the SMA and the SMV, two lethal arteries that if we damage or thrombose them, intra-op or post-op, the consequences are catastrophic for the patient. And so we specifically started to look at that and did a number of animal studies for a year because I really wanted to make sure that it was going to be safe around those structures. And yes, because of the ability to deliver those high voltages, nearly 3,000 volts, but in that short pulse lengths, we were seeing that we were able to damage the endothelial, and we actually were eradicating the cancer as well as damaging the endothelium and the vessels, but it was over a prolonged period of time, almost 8 to 10 weeks. And so those endothelial cells, just like hair follicles, were able to repopulate, and we weren't seeing that type of thrombosis. And so that allowed us to then get into that locally advanced space. Now, this was simultaneous with us starting to see more active systemic chemotherapies. So there was a lot of, I would say, reticence about using this because we didn't really have standardized systemic chemotherapy in 2008 and 2010 for locally advanced. So a lot of people were still very therapeutically nihilistic about it. And so being able to work with our medical oncologists to identify active chemotherapeutic agents as well as locally advanced allowed us to really force the oncology community to unlearn that all stage 3 pancreatic cancers are metastatic. Because up prior to 2000, probably 12 or 13, every trial looking at systemic chemotherapy always bundled them together. Stage 3 and stage 4 were the same. There was no difference. They were all allowing us to select out patients and effectively ablating their primary tumors and seeing these patients live 2 years, 3 years, 4 years was really, I think, sort of a catalyst to get people to now segment stage 3s and treat them differently with higher dose radiation, with more therapeutic type of chemotherapy approach as opposed to with palliative approach. And so we're seeing that type of benefit now, that there is a different biology. We didn't think it existed, but we've been able to identify that subset, especially with genetic markers as well as just with overall patient successes.
So you use it in two different types of settings. One is de novo and other one is margin accentuation. Can you talk to us a little bit about that?
Yeah, so margin accentuation, just for our audience, is where we utilize irreversible electroporation to accentuate the margin that we know has a high incidence of margin positivity, whether that's for doing a Whipple or right-sided resection or for doing a left-sided resection. Commonly, it's around the arterial structures, the SMA being the most common, the SMV being the next, and then potentially the aortic margin or the celiac axis. So usually a third of the way into the dissection, while we're getting ready to transect, we will accentuate that margin, commonly just using 2 needles, delivering the energy to accentuate that margin, and then go on and then do a standard completion of dissection and transection. So far, in the most recent paper that we've looked at, when we looked at our last 75 patients, we've not seen any increase in surgical complications. We've not seen any increase in anastomotic complications. And those patients do as well as a patient who has had a standard resection. Luckily, their local recurrence rates are significantly less, especially when you stratify them by margin positivity. More importantly, when patients have gotten neoadjuvant chemotherapy and they've gotten chemoradiation therapy prior to surgery, is really where we've seen the benefit with IRE, because those patients can't get any more radiation, or maybe they're limited to how much radiation they can have afterwards. So if we can accentuate that margin, it really does help the patient, because their local therapies are exhausted after we've done that surgery. So in those patients, we're far more bullish about doing that. All 2Bs get it, and then the technically resectable 3s will get margin accentuation with IRE at the time of resection.
So I followed your lead and took this to a more image-guided approach where we do the percutaneous approach, and Martin and his team have done a significant amount of work as far as research and prospective trials. So Martin, you use the image-guided percutaneous approach to treat pancreatic cancer. Can you talk about your patient selection and the protocol that you use?
So the indications for irreversible electroporation or SBRT in the Netherlands and I guess in Europe, they do not really differ that much from what is going on in the United States. Things that have changed is the neoadjuvant chemotherapy, because now it is very difficult after the neoadjuvant chemotherapy to say if a tumor is truly unresectable and shoot directly opt for SBRT or irreversible electroporation. So I think that the majority of patients nowadays actually gets explored if there's a chance at least that the tumor is resectable. So the indication momentarily is a truly unresectable locally advanced pancreatic cancer that is non-metastasized. It is up to 5 centimeters, probably that should be 4, because it gets more difficult when a tumor is over 4 centimeters in size. And well, the approach, there's pros and cons to doing it open and to doing it percutaneous, obviously, but the idea is to eradicate the tumor. So we thought locally advanced pancreatic cancer with a, well, not negligible, a very small chance of a full cure. Let's go for the least invasive way. So what we do, we treat these patients percutaneously using CT guidance. We have the patients under general anesthesia with full muscle relaxation because you give 3,000-fold, up to 3,000-fold pulses. It's exposing cells to 1,500 volts per centimeter to eradicate disease. We do this first by placing a catheter in the aorta, and by doing that we can ask the technician to give small amounts of contrast and see where all the blood vessels are to make sure that all these needles are not traversing the, let's say, the SMA or the celiac trunk arteries. We have strict indications that a patient needs to be fairly healthy, so in a fairly good general health condition, because even though this is a, let's say, minimally invasive technique, we can get serious complications. So we do want the patients to be fit. Another topic of debate is portal vein stenosis, which is very often obviously an issue with locally advanced pancreatic cancer. And there is some evidence, we do routinely do that, that we can peri-procedurally place a portal vein stent. So that I think that's a specific trick to handle that. What we do, we place a catheter transhepatically in the portal vein, then do the irreversible electroporation, CT guided, and directly after, to make sure that you do not occlude the portal vein, we deploy the stent to make sure that the portal vein remains patent, and we managed to do that in well, pretty much all, for up to 3 months at least, all of the 25 patients where we tried that. We give, if a tumor is up to 2.5 centimeters, we tend to place the needles in the margins of the tumor. If it is over 2.5 or 3 centimeters, we tend to place one needle in the center of the tumor and then in the margin of the tumor to make sure that you cover the entire tumor. And yeah, we make sure that with the CT that we make a control CT at the end to check for portal vein thrombosis, hemorrhage, and complications. Normally a patient stays in the hospital for approximately 3 days in our center and is referred home, and then we do obviously tumor marker and CT follow-up at approximately 3 or 4 months, depending on if the patient is doing good. So that's.
So one of the things with in IRE or when you use it to treat pancreatic cancer, what you are concerned about is pancreatitis. And when I do this and admit the patient, we're using amylase and lipase levels. Is that what both of you use to manage that, or do you even check those, or do you see there's value in checking it?
Well, because we still do the majority in the setting of clinical trials, we do check these things. We do have baseline levels. We do not routinely, if the patient is doing fine, we do not routinely check it to see if there's pancreatitis subclinically. So no, we do not routinely do that, but obviously if the patient is having severe pain or symptoms that may be caused by pancreatitis, we do test that. We try not to traverse, because we think that's one of the reasons why this may occur. We try not to traverse with the electrode, the pancreatic ducts, so try to avoid that. And I think that the number of patients with pancreatitis or pancreatic fistula is fairly low actually with the percutaneous approach.
Yeah, we did test lipase and amylase in the PanFire-1 trial, and we always saw a rise after IRE. Well, in almost, I think in about 80% of the patients, there was a really quick rise, quite high sometimes, about 2 days after the treatment, and with nearly all patients after 2 weeks it had completely subsided. So I think you do induce a sterile pancreatitis by just destroying, the healthy pancreatic tissue as well, but they didn't clinically develop a pancreatitis. But we did see a rise and a subsequent drop in patients that didn't have the symptoms.
Rob?
Yeah, we first did our first 10 patients in 2008 or 9. We did see that rise, but interestingly, we didn't see any clinical pancreatitis. So they weren't third spacing. We didn't see any drop in their LDH. So they didn't meet any criteria of the established, pancreatitis, both at diagnosis and then 40 hours later. So after now, we haven't checked amylase and lipase in probably almost 10 years.
Okay.
Yeah.
That's good to know. And so with this use of IRE in pancreatic cancer, your center has designed and implemented many of the prospective trials, and the most recent one that you published was PanFire-2. So can you give us a brief summary on that study?
Yeah, so there was a sequel trial to the PanFire-1. PanFire-1, which was a safety trial, 25 patients. Back then, no fatalities up to 90 days, but a higher number of complications than we anticipated. So again, minimally invasive, but serious complications can occur. And then we moved on to the PanFire-2 trial with the indications, like I said, up to 5 centimeter tumors, truly locally advanced. By then, it was routine for these patients to get neoadjuvant treatment. It was a lot of discussion: should this be chemoradiotherapy, gemcitabine alone, or should it be FOLFIRINOX? Nowadays, it would be for all patients. It would probably be 4 or 8 cycles of FOLFIRINOX, and those results were actually, we had a predefined endpoint. We wanted the patients to be significantly over 14 months of survival following diagnosis of the tumor, and with 17.5, I think, we met that endpoint that was predefined, but we wanted it actually to be more. So I think that the survival benefit for the entire population that we treat is modest, but obviously from time to time you have patients where you've truly eradicated at least a large part of the disease, so they have a long-term survival. So it's not only the median overall survival you should look at, also of course the subset of patients where you've locally controlled the cancer and you've eradicated disease for at least up to a couple of years. So the results were good, but also in PANFIRE-2, a higher number of complications than anticipated, and also one fatality. This was a patient who had radiotherapy, SBRT, which was allowed prior to irreversible electroporation. And I do think there's limited data on to support that, whether this is true what I'm saying, but I'm more scared if a patient has had SBRT prior to irreversible electroporation. But that was one fatality in the PANFIRE-2 trial.
So clearly something we all who perform this procedure to be aware of. And Hester, one of the hot topics now in interventional oncology is immune response after local therapy, and you've done a lot of work in that space. Can you talk to us a little bit about immune response after local treatment?
Yeah. When we started the PANFIRE trial, well, actually when we started treating livers first, I was presenting the protocol to the whole oncology team, and our immunologist was immediately triggered by the working mechanism of IRE, like with like the cells falling apart into apoptotic fragments and the vessels being spared. That our immunologist was immediately triggered, like, well, that could be something very interesting with respect to immune responses. Then what we did in the PANFIRE-1 trial, so that was where we treated the 25 patients. In the first 10 patients, we investigated if an immune response was being elicited, because she thought, like, yeah, that might be the case. So we took blood samples from all the patients before IRE, 2 weeks after IRE, and 3 months after IRE. And we did see that there was a significant reduction in the tumor-induced immune suppression, because the pancreatic tumor itself produces suppressive cytokines, and due to that it suppresses the immune response. And because the temporary immune suppression is lifted after IRE, so there's fewer immunosuppressive cytokines, which allows immune effector cells to grow. So we saw in the first 10 patients, we did see that there was reduced immune suppression 2 weeks after IRE, and also that the effector T cells were really active 2 weeks after the treatment. There was a drop again after 3 months. So that really showed that there was an immune response happening. And also in 4 of the 10 patients, we saw a tumor-specific immune response against the Wilms tumor 1 antigen, which is suppressed on the cell membrane of pancreatic cancer cells only. And those 4 patients that had a tumor-specific immune response also had a better median overall survival than the 6 patients who didn't have this immune response. So that really triggered us to get more into the data, because they did a little bit better, but still this was only temporary, and this immune response was not strong enough to have a durable response. But it did stimulate us to go further into this subject, like how can we add immunotherapy, and at which point in time to further enhance this temporary reduction of the immune suppression by the tumor. So we in the Crossfire trial, in which we compared IRE, FOLFIRINOX and IRE to FOLFIRINOX and stereotactic ablation, we repeated these findings, and we also saw that for the SABRE group, we also saw temporary reduction of the immune suppression 2 weeks after IRE. It was not significant, but it was also there. But we also saw increased expression of PD-1 on the effector T cells after the IRE treatment. That was also correlated with improved overall survival, and that really pleads for the combination of IRE with PD-1 blockade. And that's also something that has been investigated in animals, in mice, with very good results, especially the combination of IRE and immune checkpoint blockade, because immune checkpoint blockade by itself for pancreatic cancer doesn't work due to, because it's such an immunogenically cold tumor. So the PD-1 blockade cannot go anywhere because there's no PD-1 being expressed. And with IRE, that induces the expression of PD-L1 on the cell membrane. So that gives also a window of opportunity during which you can use that. And in mice, that has been extremely effective. And then after that, another Narayanan, I don't know if you know him.
No.
He works in San Diego. Maybe it's a really smart cousin of you or something. He did the same study in mice, but then he also added another immunoadjuvant called toll-like receptor ligands, and that are very strong immunoenhancers. Through different pathways, they further stimulate the immune response, and they performed IRE and immune checkpoint blockade, and then also intratumoral injection of this toll-like receptor ligand, and had an even stronger response in the mice that were treating that way, and also when they were being re-challenged with the tumor, it wouldn't grow. After the PANFIRE and after the CROSSFIRE trial, we wanted to continue and now add immunotherapy, not only do the IRE and identify an immune response that is not strong enough in the long way, but we wanted to add the immunotherapy. So in the PANFIRE 3 trial that is currently running, we're treating patients with oligometastatic pancreatic cancer, so they are allowed a few metastases, but not too much, because we do think that when the baseline tumor load is really high, the tumor-induced immune suppression is too strong. Like we cannot overcome the tumor-induced immune suppression. So a few metastases are allowed, and we also need them. And what we are doing, we're treating the primary tumor with IRE. Well, actually, we have 3 arms. The first arm gets nivolumab only. The second arm gets nivolumab and IRE of the primary tumor, where we also take biopsies of the primary tumor and also of an untreated metastasis. And in the third arm, we inject the toll-like receptor ligand in the primary tumor. 1 week later, we perform the IRE procedure, and then we give nivolumab. We've included 17 of the 18 patients. So we don't have the results yet, but we're performing a lot of different analyses. So we're doing the biopsies, we're doing FACS analyses, proteomics, histopathology. We're performing FDG PETs. We're performing nivolumab PETs. We're of course taking the blood samples again. So we really hope that we will get a strong effect. And hopefully, the combinatory treatment, like this multimodality treatment, will prove to be the key to get a stronger, with the local treatment, get a systemic effect with memory T cells, hopefully also preventing the spread of metastases, to finally maybe have a final cure. That's what we're hoping for.
It's great. Commend your work there. And Peter, switching gears to stage 4, these patients who already have metastases out of the beyond the pancreas, what are some of the options? Is there anything new in a trial situation for these patients to look forward to?
So apart from chemotherapy, there's only one, there was a targeted treatment approved in 2007 that nobody uses, which is an EGFR tyrosine kinase inhibitor, so nobody uses it in the clinic. It's not very effective, but of late, the only subgroup of patients that appear to have some ability to target is patients who have germline BRCA mutations. So that's based on a trial called the POLO trial, international trial, where they actually had to screen 3,000 patients to find 154 patients who were BRCA mutated in the germline. And those patients were initially treated with chemotherapy, platinum-based chemotherapy for 4 months, and then randomized to placebo versus olaparib, which is a PARP inhibitor. PARP inhibitors have benefit in tumors which are BRCA mutated because of a system called synthetic lethality, where the BRCA protein is responsible for maintaining DNA health. It's a DNA repair system, and PARP is sort of a backup system. And if BRCA is deficient, PARP becomes sort of the more important way of keeping the cell healthy. So the PARP inhibitors generally are selective, and they have efficacy in tumors which are BRCA mutants. So this study did show an improvement in progression-free survival, which led to the FDA approval of olaparib in tumors which are BRCA mutated. And then there have been some subsequent studies that expand the indication now in our guidelines, including PALB2 mutations and possibly RAD51C. And so apart from those, that subgroup, which is maybe in the range of about 5 to 8% of patients with pancreas cancer, there are some mutations which are very uncommon, but there are approvals for sort of a tumor agnostic approval for immunotherapy for tumors which are MSI high. So there's less than 1% of pancreas tumors are MSI high, so we always look for them, and we can treat with immunotherapy. They can respond to single agent PD-1 inhibitors. And then occasionally you'll find a pancreas tumor, which is ROS1 mutated or ALK mutated or RET mutated, and there are drugs which are approved, pan-tumor sort of approval for those mutations. So the next horizon, we believe, is KRAS inhibitors. So there's really only one KRAS inhibitor that has shown promise so far, which targets the KRAS G12C. And that's one of the least common KRAS variants in patients with pancreas cancer. Only in about 2% of KRAS mutations do we have G12C. The most common one is G12D, as in David, but we don't have an inhibitor yet in the market. There's some in trials. But this is probably the most active area of investigation and the most likely to be the next approval in pancreas cancer. There are multiple other strategies that people are testing, including cellular therapy. There have been some isolated cases of CAR T-cell treatments targeting KRAS G12D. There are multiple combination approaches being tested. So, there's a lot of investigation going on for patients with metastatic pancreas cancer. And we're hoping that we will see some inroads made in the next few years.
Sure. Mike, you've been one of the early leaders and adopters of MR-Linac and publishing data. Can you summarize what's the data for our viewers on MR-Linac and the treatment of pancreatic cancer?
Sure. The bulk of the ablative MR-Linac data really revolve around unresectable, locally advanced patients. And it's really with the sort of premise that, sure, it'd be nice if we can improve local control, but the question is, can we improve survival? That's sort of the holy grail, right? And I think in well-selected patients, we probably can have, some potential benefit there. And I think it goes back to, if you look at sort of patterns of recurrence data, and, there's the seminal data from Hopkins looking at, causes of death in pancreas cancer patients. And local progression, despite, even limited metastatic disease, is a cause of death in patients with pancreas cancer, right? So, the question is, if you can find those patients who have a lesser degree risk of death from distant progression, and if you can prevent or delay death from local progression that otherwise would happen, whether with IRE or ablative radiation or whatever, can you impact OS in a positive manner? And so, some of the emerging ablative MR-Linac data suggests that perhaps that's true. I mean, at this point, they are retrospective data, but, I'll give you one example. So I presented some multi-center data, 150 patient series, mostly with locally advanced disease, who were prescribed 50 gray and 5 fractions, a biological equivalent dose of 100 gray, who mostly had induction chemotherapy first, and 2-year local control was almost 90%, and 2-year survival was just about 50%. There's always confounders, or there's a lot of time confounders with patients going to surgery after, chemotherapy and otherwise non-surgical local therapies. But nonetheless, I mean, at least there's I think enough of a signal there for us to explore this prospectively. So, really excited. We're launching a phase 3 randomized international trial, essentially recapitulating LAPO-7. So this would be for locally advanced pancreas patients only, who first complete an initial 4 to 6 months of induction FOLFIRINOX or gemcitabine Abraxane without evidence of, again, local or distant progression. And at that point, they would enroll and be randomized in a 1-to-2 fashion to either no ablative radiation or ablative 5-fraction radiation on the meridian Linac. And additional systemic therapy or surgery is optional after enrollment. The primary endpoint is 2-year overall survival, and this is something that will open in a few months. But there is no randomized data to date, from my understanding, of any non-surgical local therapy prolonging survival in locally advanced disease. So, the implications of this, if it were a positive trial, obviously are profound, and we're hopeful that this will show promise for another option for locally advanced pancreas cancer.
Well, maybe to add to that, because you are correct, there's no randomized controlled data, but in the very near future we will have the results of the Pelican trial. We did not discuss that. That is FOLFIRINOX alone versus FOLFIRINOX plus radiofrequency ablation, debulking the tumor, because you cannot be radical with that. The Crossfire trial, which has been mentioned, I cannot disclose the results, but we're working on analyzing the results, and out of the interim analysis came very interesting data that the distant progression-free survival seems to be prolonged with irreversible electroporation. Probably has to do with the immune response. Whether that translates into a survival benefit, well, in the very near future we will have those results. And then the Panfire 3, as Hester said, it is also almost finished. So we will have randomized controlled prospective data in the near future on SBRT, IRE, RFA on these local regional therapies. Yeah.
How wide, or what is the access for MRI Linac in the United States?
So it's a good question. The short answer is it's still a limited resource.
Okay.
I think in the U.S. So there were 2 commercially available MR Linacs today.
Okay.
At least the system that we have, which is where really the bulk of the ablated pancreas data come from. I want to say there's probably 50 or so systems.
Okay.
In the U.S. it's not 2 or
Not
it's not
huge,
5, but
right,
it's
okay, right.
it's
It's accessible.
it's accessible, exactly. So and over the next few years we're going to see increasing adoption, of course. Yeah.
Good.
Rob, any new studies or advances in the surgical area which we can look forward to?
So again, I think the main thing that we're definitely looking forward to is echoing what Hester said around the use of surgical IRE or IRE alone and the combination of immunotherapy. Phase 1b study that we finished 3 years ago showed absolutely total safety with giving nivolumab 3 days after surgical IRE with really no. The biggest issue that we've had is actually just getting the pharma studies in the United States, any of the IO studies, back interested in pancreatic cancer. And so the heavy lift has been them unlearning all the negative studies they have and then potentially being comfortable collaborating with a ablative device that actually potentially would augment their treatment. That's been a heavy lift, and that's really the goal, I think, for 2023 is finding that pharma that wants to be that kind of innovator.
Partner.
Yeah.
The frustrating part for all of us is that, for localized resectable disease or, patients who have induction chemo don't progress and then have local therapy, whether IRE or ablative radiation, is, the incidence of progression outside of the pancreas, and especially in the liver and peritoneum, is obviously the bulk of where patients progress. And then at that point, salvage chemotherapy options and other options they're very limited in terms of efficacy. So, we have a trial looking to hopefully address that, and that there's a treatment called Tumor Treating Fields, which I don't know if you're familiar with. It made its name in the world of GBM, being the most effective treatment outside of just in the last, for a long period of time in terms of improving overall survival, in addition to surgery and chemoradiotherapy. And there's some recent data now that's showing survival benefits for advanced non-small cell lung cancer. But the sort of the hypothesis is that these patients who progress in the abdomen and the liver and peritoneum have occult micrometastatic disease, probably there all along, that just hasn't grown because of the initial chemotherapy or whatnot, that end up growing over time. So if we're able to address those cells, potentially we can delay progression, and potentially you can delay, onset of liver failure or progression, peritoneal carcinomatosis that's causing obstruction or bleeding or whatnot. So tumor treating fields, may be one option to make a dent in that. And it's essentially, it's alternating electrical current. You place these arrays on the surface of the skin, and you can deliver this to the entirety of the abdomen, inclusive of the entire peritoneum and liver. And so there's some preclinical data showing efficacy against pancreas cancer. There's some early phase 2 data, and there's some ongoing randomized phase 3 data, not involving radiation, but it's chemotherapy plus or minus tumor treating fields. So, we're excited about a phase 2 trial that's opening at our institution of patients who would first receive induction chemotherapy, without progression would receive ablative radiotherapy, and begin tumor treating fields at that time, concurrently with the radiation, but also continuing out back as maintenance therapy, looking to see if we can impact at least progression-free survival by decreasing those intra-abdominal recurrences. And if there's a positive signal there, maybe that's something that can get taken to additional future phase 3 trials, and there would be applicability there for resected patients as well. So sort of a novel sort of type of treatment that you don't really think about for pancreas cancer, but I think there's reason to be optimistic, just given how effective it's been for other very challenging diseases like GBM and lung cancers.
The DIRECT trial, any updates
On the DIRECT study and the registry, Rob?
Yeah.
So the direct registry is ongoing. We've reached over 100 patients that have been enrolled in the direct registry, with over 30 patients in the control arm, so just getting chemotherapy alone. Continue to active accrual. We're looking at obviously the time that it's taken to enroll, just because the randomized control trial, which the FDA demanded us to do, randomized patients to receive chemotherapy versus chemotherapy and IRE. We've not been able to enroll a single patient in that in the United States because patients don't want to be randomized to just chemotherapy alone. So the majority of the direct patients have obviously gotten trimodality therapy, chemo, IRE, and radiation therapy, which is really where I think we're moving the needle. We're constantly continuing to enroll in those in that arm. Interim evaluation is probably going to occur after about the 115th patient, and then that'll decide with the FDA as well as with clinical leaders whether we need to continue to do that or go ahead and release that data for at least standardization and optimization of patient selection, optimization of use, and then as well as optimization of follow-up, so we know what is the best timing and utilization of this technology. Yeah.
Great. So this has been a great discussion about a difficult cancer, and based on all that we've talked today, I feel like there is more encouraging news for patients with pancreatic cancer in the near horizon. Thank you very much to every one of you for joining this. Appreciate it. Thank you.
Thank you.
Thank you.
Thanks.